Good afternoon, everyone. My name's Katie Griffiths. I work for the IO. I just wanted to say a quick welcome to everyone to this webinar, which is scheduled to start now at 2 o'clock. We are just waiting for some more delegates to come through. So we just ask for your patience for a couple of more moments as we get all delegates signed in. So we might just have a little bit of silence the next couple of minutes, but do bear with us. Just like to say while we're waiting, thank you for everyone already posing questions. We are expecting a lot of questions on this webinar, naturally. So we will have an opportunity towards the end of the webinar to take some questions. I suspect we won't be able to get through everyone's, but please be assured that all of these questions will be taken on board. And certainly in terms of the work that the IO is doing, that we do try and address where we can some of the common themes and questions that we are getting. I can see that we're now getting up to nearly 950 delegates. So I'm just going to wait a couple of more moments just to get I know a lot of people are coming from the APM webinar as well. So we just want to make sure as many of you are online as possible. Okay, we're now hitting towards 2:05. So I think we will start with some of the introductions. I'm going to hand over to Maurice Cheng first and foremost, who I'm sure you all know is CEO of the Institute of Osteopathy, who just wanted to talk a little bit more about today's webinar and just some context.
Thank you very much, Katie. Yes, a few words, and Katie's taken off my speech, so that's fine. I just a few words of context, and thank you very much for all coming in. I think this is the first time we've actually had 1,000 osteopaths on one webinar, so thank you for making a special event for us as well. Just in terms of the context of what we're trying to do today, I mean, up till now, the IO has been focused primarily on disseminating UK government guidance, mainly from Public Health England and the other developed nations, so that we can interpret that as relevant guidance in our area. Our standard practice has been to cross-reference this with other private practice MSK professional bodies, Physio First, for example, who are the private practice arm of the Chartered Society of Physiotherapists, as well as the chiropractors, the podiatrists, and so on. We've also been cross-checking with the regulators, including GIOSC, so that we have the confidence that our guidance is in line with general good, safe practice. Now, we do try to make sure that this guidance then goes on the IO website and through the Let's Talk Osteopathy Facebook forum, which is correct at the time we publish it. Obviously, we now date everything because guidance does change depending on what flavor of the week it is sometimes. We have found, however, that PPE is one area where the applicability of public health guidance to osteopathic practice throws up a number of areas and questions which are unclear. And also, as PPE has not been a normal part of our practice, of osteopathic practice, we really felt we needed to get specialists in to help us. So we may not be able to answer all the questions you have today, as there is so much we just don't know, I suppose. And also some of what we talk about today may need some further work before the IO can formally phrase this as guidance. For example, there may be issues that need to be escalated to the IO's Policy and Standards Committee for more formal consideration. Again, this is basically to make sure that we can phrase guidance in a way that addresses patient safety, as well as safeguarding you as a practitioner. Our presenters today will help you build your knowledge and provide that insight in this area. But just one point to emphasize before we start, this webinar is part of a series designed to help us all work through our plans to reopen clinics to more normal patient needs and more normal patient levels. Please bear in mind that at this point in time, as in today, we are still officially in lockdown. So just remember, our focus needs to stay with urgent and emergency cases at this point. Having said which, once government plans are announced on Sunday, we are set up to review implications of these, and we will be supporting you through what these changes will mean for you and your practice. So let me hand over without any further ado to Dawn Carnes and Ian Harrison. Dawn.
Thank you. Thanks, Maurice. Yes, the focus of this presentation is going to be on the considerations for infection prevention and control and personal protective equipment during the COVID-19 crisis that we find ourselves in. So this presentation will be in two parts. The first part I'm going to present, and I'm going to be looking at the guidance and recommendations and practice-specific considerations in respect of infection prevention control and personal protective equipment, which I'm now going to refer to as PPE throughout the rest of this presentation. The second part of the presentation is going to be conducted by my colleague Ian Harrison. He's an osteopath with experience of infection protection, prevention and control, and also using PPE in a clinical setting. So he will guide you through that in the second half of the presentation. Now, please bear in mind, as Maurice has just said, there's still lots to learn. There's still a lot of uncertainty. This information that I'm going to present is based on current information. Things may change. And of course, decisions will be based on your own personal circumstances, situations, and your own clinical judgment. So hopefully by the end of this webinar, you'll be able to make more informed, considered and sensible decisions about infection control and PPE in respect of the COVID-19 situation. So the current advice is that osteopathic care is not indicated for people with confirmed COVID-19, people with COVID-19 symptoms, and people who've recently been directly exposed to the virus, that is within the last 14 days. These people should be self-isolating, or if they're seriously ill, they should be in a hospital setting because of the risk infection to yourselves, to family, friends, patients, colleagues, and everyone else. So if you have this group of people who are COVID positive or been exposed or with symptoms, they should be in a different setting. But what about all the other people that might pitch up in your clinic? Well, this is why we need to consider infection prevention and control and also the PPE, because these people could be asymptomatic. And we know from the current research that's out there that the incubation period for the virus is around 5 days, and that people can shed the virus, so they're infectious, for 2 to 3 days prior to any onset of symptoms. So we don't know who will be infectious when they come into the clinic setting. There was a study that was done looking at infected people who were asymptomatic or pre-symptomatic, and of those 56% who were infected, who were asymptomatic and pre-symptomatic, they all went on to, not that all, sorry, 88% went on to develop symptoms within 14 days. Again, so I'm reiterating the point, we don't know quite who's going to be infectious or not. And also the prevalence of COVID-19 is still unknown, and it's likely to be changing because of the social distancing policies that we've all had to deal with over the last 6 weeks. So still a lot of unknowns, but assume that anybody you meet may possibly be infectious. Now, the government guidance, I need to put this into context before we go any further. Most of the government guidance is directed at healthcare professionals working in a hospital setting. And these clinicians are working with patients with COVID-19 or suspected, or they have suspected COVID-19 disease. There is some advice available for primary care, community health and social care settings, but this is for essential care delivered during the lockdown period. The advice for non-hospital setting care for direct contact care is not so clear. So, why do we have to have standard infection control procedures? Well, of course, they're required to try and reduce the levels of transmission. And there's three types of transmission. There's contact transmission, and we know that the SARS-CoV-2 virus route is via the contact with the mucosa. There's also transmission via droplets. This is when somebody coughs or sneezes or even talks. And these droplets actually fall to the nearest surface or the ground relatively quickly. But then we also have airborne transmission. And these are smaller particles. These are called aerosols. And these can be airborne and remain viable in the air for up to 3 hours. And these can be produced with aerosol generating procedures. And we're going to talk more about those later in the presentation. The standard infection control precautions recommended by Public Health England were published in April 2020, which is not that long ago. So hand hygiene was obviously one of the major public health messages that we all received, and this includes washing our hands frequently with soap or alcohol-based hand rub. So not only our hands, as osteopaths, often our contact with patients is further up our arms if we have exposed arms. So here we're talking about hand hygiene extending up the forearms. Hand hygiene is needed before and after each patient contact, before and after leaving treatment rooms, and at any other point in the consultation where you think you might have had contact with any of the virus. So removing jewellery, watches, keeping the fingernails short are also helpful to optimise hand hygiene. Other infection control precautions include gloves, and this is for contacts with patients in an epidemic or pandemic situation. Respiratory cough hygiene, catch it, bin it, kill it examples with a tissue or actually sneezing into your elbow, combined with frequent hand washing or hand sanitizing, are also standard precautions. Other precautions, which I'm sure you're aware of, is keeping your hands away from your face, the use of masks for clinicians or those with respiratory symptoms, the 2-meter social distancing, which of course, if you're doing a therapy like osteopathy, is almost impossible. Well, it is impossible if you're going to have manual contact. And then also there's cleaning, disinfecting equipment and services, waste disposal, cleaning linen, so reversing the linen and storing the linen in closed bags, ready for washing at a minimum of 60 degrees with detergent. And of course, a final precaution that we're going to cover today is ventilation. This is about air exchange and droplet dissipation. So what is exactly the government guidance? Well, the government guidance is very COVID-19 specific for PPE. Now, this guidance is that which is recommended for a primary care setting. It's also for community and social care settings, but for us as primary care practitioners, this is why it's relevant to us. So if you look at this table, this is what the guidance recommends. If you're a clinician providing direct care to a patient, so with contact less than 2 meters, the guidance says you should be wearing a mask, a water-resistant apron, gloves, and you need to risk assess on a case-by-case basis if you need eye protection. If you're a clinician providing direct care to a patient with a potentially aerosol generating procedure, then you need more fuller PPE. And this includes a mask, a filtration mask, water-resistant gown, gloves, and eye protection. For clinical personnel working in reception areas and communal areas who are not always able to maintain 2-meter distancing, it's also recommended that they wear masks. Now, for the patient, if you're providing direct care to a patient, you need to risk assess whether they need to wear a mask. If you're going to do a procedure that might generate aerosols, then you should really ask your patient to wear a mask. That is now in the guidance. When we look at infection prevention and control, you can see here that hand hygiene is a must. Cleaning between patients is also a must. Aeration between patients if you're doing direct care or with an aerosol generating procedure. Communal areas, I think you need to risk assess as to whether you need to aerate between patients. Gloves, gowns and aprons are single use and they're recommended for patient contact. For those who don't have patient contact, they are not recommended. Mask changes, these are required when the mask is moist, damaged or removed, and for AGP procedures for single use per patient. And again, for people working in communal areas within a public setting, if they can't maintain that 2 metre distance, then again, masks should be changed once moist, damaged or if they've been removed. And linen, if you're not wearing any plastic protection, should be changed between patients. And this isn't really relevant for personnel who are not having direct contact with patients. So let's look at some of the rationale and reasoning behind these recommendations. Well, the rationale for masks is to reduce droplet and airborne infection. And there's different types of masks, and some are designed to prevent the dispersal of droplets, for example, from coughing and sneezing. And other masks are more sophisticated, and they're designed to protect the wearer by filtering particles. So you have cloth and paper masks. The aim of this is to reduce droplet dispersion from an infected person. And these are the type that you might see people in wandering around town wearing. Then you've got surgical and procedural masks. The aim of these is to reduce droplet dispersal, but they also have some personal protection via particle filtration. It's estimated that fluid-resistant surgical face masks and those called FFP1 masks give about 35% particle filtration of the larger particles. They can be flat, pleated, sometimes they're cut, they're generally loose fit and single use. And then we go up to higher specification masks, and these are designed for personal protection to filtrate particles. These are often referred to as N95 masks or FFP2 masks, and these are designed to filtrate particles of 300 nanometers or over. Unfortunately, the coronavirus is slightly smaller than this, so it doesn't offer total protection. If you want total protection, you have to use much higher grade, more sophisticated respirator masks, and these are very tight fit and good seal is required around the face. So what about the effectiveness of masks? Well, fluid-resistant surgical masks and higher grade masks are better than no masks at all. Fluid-resistant surgical masks are recommended for symptomatic people to prevent droplet dispersing from coughing and sneezing. Now, in a clinical setting, there's no benefit of fluid-resistant surgical masks over N95 and the other way around. In a laboratory setting, there is. So this is why you really have to consider the behaviour and how you use your mask to gain maximum benefit and effectiveness of use. Fluid-resistant face masks, N95 and FFP2 masks are recommended for use by healthcare professionals. Cloth masks are not, and in fact there is an increased risk of infection with cloth masks. They don't provide any particle filtration at all, and they get moist very quickly. Taking them on and off can often increase the possibility of getting viruses within the mucosa on your eyes and nose. So mask use is very effectiveness is very much dependent on keeping the mask on, changing the mask when it's moist, changing damaged masks, also for the fit for maximum filtration, and also it depends on whether these masks get contaminated from poor hand hygiene or poor donning and doffing procedures. So now I want to do a little bit about aerosol generating procedures. An aerosol generating procedure is any procedure that may stimulate or assist a cough or a huff, such as a like that. And these procedures are mainly done in a hospital setting with ventilation techniques. But there was a study that was done in 2010 during the 2009 H1N1 flu pandemic, and this looked at chest physiotherapy. And what they found was that chest physiotherapy did increase droplet production, and these particles precipitated within 1 metre of the patient. Now, there's no specific guidance on aerosol generating procedures for manual therapists in non-hospital settings. But I really think as osteopaths it's useful to consider the type of techniques that we administer to our patients. So any patients requiring deep inspiration or expiration or chest compression techniques. So I'll give you an example of a patient lying supine for a thoracic adjustment, which you might use a dog technique. You've got your hand underneath the patient's back. You might be using your body weight to compress the patient. And at this point, consider how close your face is to your patient's face. And you can see why PPE is required in those circumstances or situation. You're in a close proximity. There is a risk of aerosols. So here you'd be looking at full precaution droplet PPE and also giving a mask to the patient if you think they might cough or deeply expire. There might be more work that's needed to be done in this area in the future. So the next thing we're going to consider is aeration. We know that breathing and talking can produce low droplet concentration, and coughing and sneezing can produce high droplet concentration. So therefore, aeration is important to reduce the viral load and concentration in the air, because we know that tiny particles can also remain in the air for 3 hours. We know that aerated rooms are safer than closed spaces, and that regular ventilation of closed spaces is advisable. The World Health Organization recommend a 20-minute ventilation for 2 air exchanges. But of course, 20 minutes is a bit arbitrary. It depends on air currents, the size of the windows, the size of your room, for example. But one thing that does come across is that you should be avoiding systems that recirculate the same air, such as fans in a closed environment. So let's look at hand hygiene next. The virus is surrounded by a lip layer, and it can be effectively inactivated or destroyed by detergents, so liquid solvents and salts, by ether ethanol alcohol at higher concentrations than 70% and above. Disinfectants can also inactivate the virus, as can some ultraviolet rays, but only with direct exposure and only with certain wavelengths of ultraviolet rays. These aren't practical in a normal situation. And we also know that heat can destroy the virus. Now, for hand hygiene, obviously, you're not going to be able to wash your hands in high temperatures like this, but we know that heat can destroy the virus. We also know that the virus is active on different surfaces for different lengths of time. They can be active for up to 7 days in optimal conditions. The length of time that a virus can survive is really dependent on the surface, the type of surface, whether it's porous or not, and the conditions such as moisture and heat. But do be aware that the virus can be active, and that's why contact transmission is so important for us to consider. Gloves. Now, gloves are recommended in the guidance, and the reason why they're recommended is from a general principle that they reduce the risk of contamination of healthcare worker hands with regard to blood and other bodily fluids. The idea is that they can reduce the risk of germ dissemination into the environment and transmission from health workers to patients and vice versa. They do provide a barrier to pathogens, and their effectiveness is dependent on whether they're combined with good hand hygiene, remembering to change gloves, not touching the face with the gloved hand, and again, how used, how you put them on and how you take them off safely. Aprons and gowns. Again, these are recommended in the government guidance. They act as a plastic waterproof barrier against droplets on the practitioner's clothing. They're for single use only. And the idea is that they reduce cross-contamination, transfer of droplets between you and your patients. The actual evidence of effectiveness for reducing infection rates, however, is limited. And again, effectiveness also depends on how these products are used. Cleaning and disinfectant, this is essential. We do know that detergents and bleaches can destroy the virus, and they can destroy the virus within 1 minute of contact with the product, depending on the concentration. So this is an absolute must, cleaning between patients. But before we go any further, I'd like you just to think about your own personal risk assessment and how you're going to reflect on practice once lockdown is reduced. So you need to consider your own acceptable risk levels, and this could be due to your personal health, the health of others around you, the vulnerability of yourself and those around you, and the consequences of being ill. And these things may affect your decisions about the type of masks that you use, when to use eye protection, the use of aerosol generating procedures, how you treat people, whether you treat them supine or prone more often, and at what point you ask a patient to wear a mask. There's also financial considerations. There's the additional cost of doing infection and prevention control, the cost of PPE, splash screens, for example. There may be some reduced capacity in your clinic as you need to consider cleaning time between patients, and the volume of patients might reduce. And you also need to consider changes perhaps to payment systems. You will need to reflect on hand washing facilities, PPE, and appropriateness of cleaning products. There is also clinical environmental considerations to consider in terms of patient flow and social distancing and any cleaning regimens. And these are the practicalities of care, and this is what Ian is going to talk about now. So I'm going to hand you over to my colleague who's going to give you a little bit more information about the practicalities of implementing infection control procedures in PPE. Thank you very much.
Thank you very much, Dawn. I'm just going to switch over to Ian, who will continue with the presentation. If I could ask for delegates' patience while I just get the technology working. And hopefully, Ian, you should be able to share your screen. Thank you very much. We've got a Word document up there, Ian. We can get your presentation. Great, that's lovely. We can see your presentation now. Thank you very much.
How's that look? Thanks, Dawn. We were given this task
that's great.
early last week.
Ready when you are, Ian. Thank you very much.
What I hope you'll find is the content of what I'm going to be talking about. Hi, everybody. Thanks for tuning in. I think we're up at 1,185 people watching at the moment. And hopefully at the end of this, you'll hear repetition of what's been spoken about on various platforms and webinars and Facebook groups, because the information that we're all getting now is converging to be fairly consistent. And I hope this starts to clear up some of the confusion and some of the anxiety. I come from this from a slightly different angle. I'm still seeing patients. I saw a patient earlier today. I have an MSc in evidence-based healthcare, and so I bring a different angle to this subject. And I've been asked to talk about PPE. I'm more interested really in behaviour than PPE. We've been rushing around trying to source PPE but not knowing how to use it correctly. And this is where clinical science and behavioural science meets. And unless we understand its use and we understand a little bit of the activity of the virus, even the best PPE leaves us rather vulnerable. We're going to talk about triaging, and I feel personally triage is your first PPE. This is the most protective barrier, the first barrier that you're going to put up when you contact your patient and ask them about their clinical symptoms and any potential risks with their respiratory symptoms. We're going to talk about hygiene, respiratory hygiene, hand hygiene, room hygiene. But very importantly, nothing that you're going to do in your practices will reduce your risk of infection to zero. And just being in practice increases your risk. Just going to the supermarket increases your risk. And so this is about reducing viral load. I watched a brilliant webinar this morning by Paul Voucher, and I've stolen one of the slides here. And this is a slide showing density of vira across time. And this point here, 0 point, is onset of symptoms. And this shows when the patients are at their most infective. And as you can see, somewhere between 2 to 2.5 days, the viral load in the patient is at its highest even before they're developing symptoms. So you simply don't know who's infective. And using symptoms alone is not a good guide. And we need to get good at this because this virus isn't going away, and getting comfortable with managing it and accepting some of the changes is going to make your life going forward a lot easier in practice. It's not a plug because I've not seen this presentation until this morning. This was written, this was put up by Come in Switzerland, and Paul was very funny and attractive and actually very simply put presentation, which goes into what we're talking about today in much more detail. There are two things in there that I think need a little bit more explanation here in the UK because of our some of the restrictions put on our practicing. One is around triaging, and the second is about the treatment of active and confirmed cases. And of course, in the UK, we're not treating active and confirmed cases, and I suggest that anybody who did was perhaps exposing themselves slightly to invalidating their insurance. The IO have given us this flowchart, which talks about the need of the patient to see us in an osteopathic context, but doesn't talk particularly clearly about COVID, and your triage must include whether they have any of the well-known symptoms of COVID, the contact of COVID, or any of the other points raised by Dawn in her presentation just gone. And the theme across the world amongst my colleagues in this country and in the Southern Hemisphere is consistent everywhere. We're all struggling with the guidance at this point in the pandemic, but it's coming together and it's getting more consistent. Our biggest challenge, without question, is the pre-symptomatic and asymptomatic infectious patient. We just don't know who they are. And I think we have to divide the population into two separate groups. Those people with confirmed COVID or strong symptomology, and everybody else. And everybody else may in fact be an infection risk. Everybody is frustrated by the availability and the practicalities of use and the effectiveness of PPE. Our practices are all different. Our access to our practices, the design of our rooms, the locations of our practice, our patient types, all different. It's almost impossible to set guidance that is going to apply to everybody the same. And so this is where your own individual risk assessment can become very important. And there's true fear and a little anger about the future and what's been taken from us as little as 10 weeks ago. We want things to be the same again, and they're simply not at the moment. And these questions, I think, are the questions, the key questions we should be asking ourselves. And if we can answer these with honesty, then you're running a very good practice, and patients should feel very safe coming to see you. And are you acting with professional integrity, and is your clinical judgment sound and evidence? Do you have a safe triage, and who's doing the triage? I think it's inappropriate at the moment having a receptionist triage patients for a virus like COVID that we don't fully understand yet. Are we gathering patient information in a safe and best way? Do we need to collect that data before the patient arrives via email or telephone so that we're minimizing the amount of time patients are in our reception area or in our consulting rooms. Is the social distancing and PPE strategy that you have in place, is it working and is it appropriate? Are we dealing with waste appropriately? How are we doing our laundry? How are we cleaning our clinics? How are we disposing of our non-clinical waste? And with all of those things being considered, do you have local policies in place that you can ensure compliance across your practice and that you're being consistent? So if you don't have these policies in place and you don't measure them, you don't know if they're working or not. Very quickly, we've all got the same challenges. Everything's going to cost a little bit more. The supply chain disruption has put prices up. Training of our team, structural changes to your premises, buying PPE and using different hygiene techniques. Our patient numbers are going to be down. There's going to be enormous anxiety amongst our patient populations about coming in, having a hands-on consultation. Practitioner anxiety has gone up because practitioners may be more anxious about seeing certain types of patients. There are huge economic pressures coming around the corner with high levels of unemployment and less cash in the system, and it may well be that that has a direct impact on our patient numbers. And you hopefully will be changing some of your practice procedures at the moment to ensure that everybody's safe in your practice, and this may be increasing distances between gaps between appointments to allow proper cleaning and aeration. We also have that pressure that Dawn talked about our own health and the health of our loved ones and the health of our colleagues and the health of ourselves when we're exposing ourselves to potential infection. And there's that enormous pressure to keep the business running, to cover your costs, to support your community. But I'm also a terribly optimistic soul, and I think there's also opportunities to look at facilities and procedures within your practice. We've got the time at the moment. There's an opportunity to improve in the long term your overall hygiene. COVID's not the only bad guy in town. We've got staph and MRSA and E. coli and norovirus and seasonal flu coming up towards the end of this year, as it does every year. We've got the opportunity to use technology better and communicate with our patients better. We're already doing this with the number of technologies that have thrived, unfortunately, during this pandemic. And we're already working much more closely. We're now up at 1,181 people. We're working together, we're sharing information. People are putting out a huge amount of effort to try and help our colleagues understand this situation a little bit better and to work a little bit more safely. And we're all learning not to touch our faces quite so much. So basics, soap and water. Dawn's explained this from a clinical point of view very clearly. This bug gets into your eyes, your nose and your mouth. The soap destroys the lipid layer of the virus, and by destroying the lipid layer of the virus, you inactivate the RNA within the virus. It can't insert itself into your mucosa, and we get to wash it down the drain. You have to wash your whole arm. We use our whole arm when we're in contact with patients. Scrubbing creates friction. Friction lifts the virus and other microbes off your skin, and this takes time. This takes seconds, multiple seconds to work effectively to get them off all the surfaces on your hands. Don't forget your nails. And the reason we rinse under running water is because we want to wash that soap and the associated microbe down the sink so we can't reinfect. And the temperature of the water is irrelevant. It doesn't matter whether it's warm or cold. And in fact, the advice seems to be that cooler or cold water is kinder to your hands over time and will cause a little bit less damage to your skin. Once your skin becomes damaged, it begins to break down and the epithelial layer becomes breached, and there's an opportunity for infection that way, not just by COVID, but by other bacterial microbes as well. And there's no difference between antibacterial soaps and standard soaps. This is a virus. It doesn't respond to antibacterial products. I have all my patients, the few patients that we're seeing come and wash their hands before we start, and they are appallingly bad at washing their hands. They do it very briefly. In fact, I've got to the point where I stand and watch them wash their hands to make sure it's at least partially effective to reduce the risk of them infecting me. There's a very simple slide which I think most of you will have seen. This is a thing called glow germ. If you put it all over your hands and then shine a UV light on it, you can get to see where bacteria may be deposited around the surface of your hand. And the top row is washing your hands without soap for rinse and shake, which we've all been guilty of. The 6 second with soap, and then the bottom row looks at the application of soap in addition to using soap. 6 seconds, 15 seconds, and 30 seconds. And I think it's pretty self-explanatory. The advice over the last decade or so has changed with hand sanitizer is that hand sanitizer is to be used when washing your hands is not an option. It's not a bad thing to do, and in the absence of soap and water, it's an extremely effective mechanism for reducing microbes on your hands. The alcohol content needs to be in excess of 60% and perhaps even higher. That's yet to be established. And again, if you're going to be washing your hands to your elbows with soap and water, you need to be washing your hands to the elbows with sanitizer, and that could prove rather expensive over time. You have to rub over the entire surface, and there's a gel associated with the alcohol, and the job of the gel is to keep the alcohol on your skin for long enough to kill the bugs, and the bugs can take 30 to 60 seconds to die. So a quick smear on your surface of your hands and then touching items around you won't have had the desired effect. Continuing to rub until your hands are dry and then keeping them away from any contact for 1 minute is a much more effective way of ensuring that you get proper kill. And of course they can cause dermatitis, and again dermatitis can damage the surface of your skin. I'm not going to talk too much about gloves because Dawn's covered it very nicely, but the evidence is weak, but they are in the guidance, and if you're not wearing them, you're outside the current guidance. The key benefit appears to be behavioural. Gloves are a strong reminder not to touch your face. They give a false sense of security. We've all seen those people in supermarkets and gas stations who are busy scratching their hair, scratching their face and correcting their hair with their gloves on, and actually infecting either their gloves or their face. And importantly, gloves aren't entirely waterproof, and they are slightly porous, and so your hands have to be clean before you put them on in the first place. And if you have been unlucky enough to develop a dermatitis, or you do have sores from too much gardening during lockdown, putting a glove on protects the surface of your skin from any other microbes that may be lurking in your consulting room. Masks, again, covered nicely by Dawn. They are a barrier. They're originally devised as a barrier from me to the patient, and but it's clear that they operate as a barrier from the patient to me with large droplets, but not aerosols. In our context, unless we're producing aerosols through procedures that we're following, the fluid-resistant surgical mask is enough and is adequate. Homemade masks are not recommended in a healthcare setting. And these masks can be used for a session. Now, a session is deemed as 4 hours. This is a very uncomfortable thing to leave on your face for 4 hours, and I suggest you wouldn't make it. They should be removed when they become moist, when they're damaged. And most importantly, you cannot take them off and on and off and on. Once they're on, they're on. Do not reuse them. And masks are just part of the triad of things that help us stay safe: hand washing, social distancing, and face masks. And some countries have moved to face masks in all public spaces. And I suspect that may be a message from Boris later. I won't go through the specifics of donning and doffing because this is available on the public health website, and you all have access to that. But I will go through a couple of important points that when donning your PPE, wash your hands before you start. If you don't wash your hands, you risk infecting all of your PPE before you even get started. So a good thorough hand wash to the elbows, then don your PPE. Doffing PPE, same message here. Clean your hands, clean your hands, clean your hands. Dawn asked me to talk about taking off masks from a personal experience she had, and I'll go over that in a moment. So taking off, I couldn't help putting this slide up. This is a brilliant demonstration of what not to do. This gentleman here standing in his water-resistant gown is wearing a watch. He has a full beard on underneath his mask, and his stethoscope is perfectly dangled around his neck to get reinfected for the next patient that he's going to see. Masks, avoid touching the outside. This is usually the blue side of the mask. Take it off from the elastics at the back. You're either untying or you're flicking them off your ears, and you drop them away from you into a pedal bin that has a closed lid, and once you've taken it off, do not put it back on. Aprons, avoid touching the external surface. Undo the ties from the back, fold it on itself, drop it into your pedal bin, and close the lid. Several questions have been raised about using reusable clothes, so perhaps having multiple clinic gowns that you would be wearing. And this appears to be okay, and I think the IO has given this the nod. Needs to be reassured on that. But if you are going to change between patients, take them off as you might take off an apron. Don't pull them over your head, because you risk infecting your face when you pull them over your head. They've got to be able to be taken off safely and without increasing your infection risk. Bag them up, take them home, launder them under the manufacturer's guidelines. Use the warmest water setting that you can, and this is recommended to be over 60 degrees. So be very careful of the fabric you're going to use. A scrub suit here, you can almost oil wash without damage. I suspect that some more gentle fabrics are a little bit more vulnerable. I've thrown this in if I've got time, and I won't linger too long. This was something in the Nursing Times that I read yesterday, which is what they're recommending for nurses at the end of a working session, the end of their working day. And these are people exposed to high viral loads in hospital settings. Wash your hands and forearms with soap and water and let them dry. Remove, if possible, your uniform, change into your own clothes, put your uniform in a bag. When you get home, wash your hands again. Put the washing in a machine and wash it by itself at the highest temperature the fabric can tolerate. Iron and tumble dry. This virus hates dry environments. It dehydrates very rapidly. The drier the surface, the harder it is for it to survive. Throw away the plastic bag, unfortunately into landfill at the minute, that you carried your uniform in, and wipe down your phone. And the things you don't need to do is avoid family members, shower immediately, or throw everything away that you've used to dry yourself after your shower. This is an image of one of our consulting rooms that we were lucky enough to refurb about 18 months ago, and we followed the PPE guidelines. And I want to talk very briefly about how we managed that design. And I know this is impossible for the majority of people with their current design of buildings, but these are things to think about going forward. We're going to talk about the floors, furniture, couches, pillows, hygiene, cleaning, and air movement. And rather embarrassingly, sitting here in the right-hand corner is a upright fan that hasn't been turned on since the outbreak and will be disappearing from the room next time we're in. Floors should be washable ideally. They should be non-slip, because when you wash them they become slippery, and it's pointless having a washable non-slip floor if you don't actually wash it regularly. And there's an article coming out under the CDC in the US, is coming out in July, but we've seen an early release, and they found coronavirus in the pharmacy of hospitals, which could only have got there being transported through on the feet of the clinicians in the high-risk areas. Furniture should be simple in design. I'm not plugging IKEA, but that costs 30 quid from IKEA. It's wipe downable with a funky design. It's reasonably comfortable. And again, don't forget to clean it down. Couches and pillow slips, they should be non-porous, they should all be wipeable, they should be cleaned thoroughly between patients. They ideally should have hands-free operations, so you're not grasping a switch to put the table up and down regularly. Avoid couch covers and pillow slips. A bit of a personal hate for me, couch covers and pillow slips, because they are the most unhygienic surface, for not just for viruses, but for bacteria as well. Clean the surface thoroughly between patients. And couch rolls. Couch rolls seem pointless, but they do catch somebody fluids, and it is paper, and you can dispose of them relatively safely. Hygiene stations, somewhere where you wash your hands, where your paper towel dispenser is, where your pedal bin is, where your surface cleaning agents and disinfectant sprays, they should all be in ready access to you. They should be right there for you to use. And also make sure you clean this area frequently. This is a high volume area. This is where your patients will be washing your hands, where I'll be washing my hands, where I'll be placing and replacing cleaning products. Cleaning frequently touched surfaces like door handles and light switches, and the flusher on loos, and any other surfaces that are contacted by me or by our patients. And the whole discussion around room ventilation will emerge over the coming weeks. In-car waiting, staggered appointments, getting people to leave the family at home and coming on their own, so you've got the smallest number of people in your consulting space. Minimise what they bring. When we talk to patients, we ask them not to bring too many things, so we don't want a handbag and a coat and an umbrella sitting around the consulting room, which increases infection risk and actually reduces the ability to clean. Zone areas and waiting rooms if you've got multiple people in the space. Try and get good at corridor and stair etiquette so people aren't unnecessarily bumping into each other. Think about your payment zones. Think about prepayments or invoicing afterwards or contactless payments. And if your receptionists are face-to-face with patients, you may need to think quite seriously about splash guards or masks. The whole issue around clinical waste is very difficult, and there's a document here with a hyperlink if you've got the time. There are flowcharts in there that can tell you exactly what your waste is, and unless you're using sharps like acupuncture needles or podiatrists using scalpels, most of what we generate as non-clinical waste can be double bagged, left for 72 hours and then disposed of as normal waste. In quick summary, be open to the short, medium and long-term changes. They're in everybody's interest. They're in the interest of keeping us safe. They're in the interest of keeping your family safe, your colleagues safe, and your patients safe. PPE is a short-term reality, and we have to get over that. The challenge is getting hold of it at the moment and the price we're having to pay. Triage yourself at this stage of the pandemic. I don't think this is something you can delegate to a non-clinical member of staff. Shield your mouth and nose, and if you have to, under your risk assessment, shield your eyes. Wash your hands and don't touch your face. And I think that's my lot.
Ian, thank you very much. Sincere apologies, we did have some sound issues through Ian's presentation. Hope they were resolved towards the end. We are recording the webinar and we are hoping the presenters will be allowing us to share their slides. So if there are any elements that were missed, then we can share them with everybody. We are getting numerous questions in, so I think we've got time to have some questions for our presenters. So I'm just going to just pick out some of the main themes there, and Dawn, I'm going to bring you in as well in terms of voice. Couple of questions around touching on the idea of aeration, and firstly the question around fans versus aircon machines versus air purifiers. Are there distinctions between those in terms of note all of those, or are air purifiers or particle catchers, those with particle filters, have Dawn, you are
there. Katie,
Are you on it, Dawn? Are you?
Yeah, Dawn, we can hear you.
Oh, great. Great. Okay. Well, I really don't know much about air filtration systems. It's not my area of speciality. And I think whatever air filtration system you have to check with the manufacturer. And you've got to remember these particles are very, very small. If you're thinking of filtering, I think you're going to have very specialist equipment. But aeration and ventilation are thought to be useful in dissipating and diluting the viral concentration within the atmosphere. And it all depends on air exchange, air currents, and throughput of air. And that depends on your room, your windows, the size of the room. So that's a very, very difficult question to answer. Ian, do you have any other things to add?
Sorry, Dawn, I didn't mean to.
Well, Paul talked about that on the webinar that
We have got a bit of a delay.
Are you okay? Paul talked about that in his webinar that I referenced earlier. The problem with the sorry. I'll try again. So Paul discussed this in the webinar I watched earlier this morning and detailed it reasonably well. One of the problems with any sort of recirculation is what you do is you maintain the aerosols in the air that may either escape or drop to the floor where they're more easily managed. Air conditioning units are recirculating, so all they may do is turn droplets into smaller particles and recirculate them for you to breathe in later. I had a look on the Dyson site with their HEPA filter, and although they felt that Dyson could play a role, the filtration size of a HEPA filter doesn't stop the size of a COVID virus from passing through. So I don't want to have false reassurance that would be safe. There is another thing called a PPE filter, which I've been doing some reading about, which I don't quite understand the mechanics. But again, I don't think there's any evidence around their safety.
Thank you, Ian. Thank you, Dawn. We've had a few questions on is around if you have carpeted clinic rooms. Does anyone have, Ian, maybe if you have any experience with that? Have you always used or not had any experience of carpeted clinic rooms?
I'm pretty sure this is going to relate to the vast majority of people watching this webinar right now, and so I'm going to choose my language very carefully. I think that we talked about looking forward post-lockdown and what that may look like. And I think if we were being very aspirational, we would suggest that one of the medium to long-term hopes would be that carpet was seen less inside a clinical setting. They're very hard to look after. The only way you can really keep a carpeted floor clean is with a vacuum cleaner. And unfortunately, vacuum cleaners potentially can cause, it can be responsible for aerosol generation.
Thank you very much, Ian. I say again, apologies, we have got a delay on the sound here, so I think it's making it difficult to do a lot of the Q&As. We have had a question, and again, a couple of things about PPE suppliers and whether there are some concerns about reputable suppliers or not. I'm going to try and ask this question of Morris from CEO from the IO in terms of what we may be doing in terms of providing the work that we're doing trying to identify PPE suppliers. Morris, would you like to answer that question?
Just a quick answer on that one. Yes, we have been deliberately going around buying sample boxes from suppliers of a variety of provenances, and I think we've so far located about 3 or 4 where we feel that in fact we have verified that the masks particularly actually what we're focusing on are of appropriate quality. They are actually have the right markings on them. I mean, be very careful certainly from our experience that there are many suppliers, particularly on eBay and and on Amazon, for example, where you will get very strange looking stuff coming through. So we've been buying sample boxes, and we will be publishing a short but growing list of suppliers that we have actually got good content from, probably next week.
Thank you very much, Maurice. I'm just going through some more of the questions. I think we may have tackled this, but if Aprons versus changing clinic codes between patients, do we have a view on that, Ian or Dawn?
The guidance is quite clear that if you're doing normal contact with a patient, you should be wearing a plastic apron. That's what the guidance says. What you choose to do in terms of infection control and infection prevention and control, in terms of changing your uniform or your clothes between patients, that's probably a suitable alternative. But the guidance does specifically mention the use of plastic aprons as a barrier. I suppose if you can't get them and you can change your clothes between patients, great. But you have to consider how much of your clothes come into contact with the patient, and what's a reasonable change of clothing and how much clothing you have, which is why the disposable aprons are recommended.
Thank you very much, Dawn. As I say, due to the sound delays and some of the quality issues, I think it's gone 3 o'clock, so we'll call that for now. What we will do is we are going to take all the questions that we've been posed and put together a frequently asked questions. So because there are lots of questions from people, we won't be able to deal with all of them. So we will pull out the common themes of those questions and circulate those to all delegates, so that everyone does have some response to some questions where we do have the answers. To reiterate again, we may not have the answers to all your questions, and some of them are very specific, obviously, to your own personal circumstances, but we will obviously do our best. I just want to extend my sincere thanks to both Dawn and Ian for really sharing that insight and providing their experience and views in their relevant areas. As Maurice has said, we are doing a lot of work in terms of ensuring that we can provide the profession guidance going forward as we move out of lockdown. If everyone does have any further questions, please do email them in on the email that you will have got on your email registration. And I think other than that, I'd like to just say a final thank you to everyone, and thanks again. Thank you very much, Ian and Dawn.